On January 14, 2026, prescription refill processing in New Jersey began encountering delays that pharmacy management systems logged as minor latency increases in authorization response times starting at 6:47 a.m. Eastern. The first flags appeared in eligibility verification queues at independent pharmacies in Bergen and Middlesex counties, where prior authorization requests submitted between 6:30 and 7:15 a.m. registered average response delays of 4 minutes and 12 seconds against a baseline average of 48 seconds. Chain pharmacy operations centers in Morris and Essex counties recorded similar patterns in their centralized adjudication systems, with insurance verification steps showing completion rates of 73% within the standard 2-minute window compared to the normal 96%. These delays occurred without error codes, timeout messages, or system unavailability notifications. The insurance clearing platforms remained online, the pharmacy benefit manager portals displayed normal status indicators, and the state prescription monitoring program database responded to queries within documented parameters. Morning shift pharmacists at 42 locations documented the delays in operational logs as connectivity variations, noting that refill requests were entering verification queues and advancing through initial eligibility checks, but experiencing what workflow tracking systems classified as extended dwell time and authorization substeps. The delays were consistent enough to affect queue progression, but irregular enough that no single pharmacy location registered the pattern as a systemic issue during the first 90 minutes of the shift.
Between 8 and 10:30 a.m., the verification backlog across New Jersey pharmacy systems grew from an estimated 218 pending authorizations to 1,473, distributed unevenly across independent, chain, and hospital-affiliated pharmacy networks. The rate of authorization completion dropped from an average processing velocity of 87 refills per hour per location to 31 refills per hour per location, while the rate of new refill requests entering the system remained within normal parameters for a winter weekday at 112 requests per hour per location. Pharmacy workflow management systems began automatically reassigning staff from inventory reconciliation and consultation duties to authorization queue management, following protocols designed to address temporary spikes in verification volume. This reallocation reduced available capacity for prescription filling, quality verification, and patient consultation by approximately 40% across the state's retail pharmacy network. Insurance verification steps that normally required pharmacist intervention in 8% of cases began requiring manual review in 29% of cases, as automated adjudication processes returned ambiguous status codes that workflow systems could not resolve without human decision points. The pharmacy benefit manager networks serving New Jersey reported inbound query volumes within their documented capacity ranges, with no reported system degradation, maintenance windows, or processing interruptions. Authorization requests continued to enter their systems, advance through initial screening steps, and queue for final approval, but completion rates remained suppressed without generating the error thresholds that would trigger automatic escalation protocols or vendor notification procedures. At 10:47 a.m., the New Jersey Board of Pharmacy received its first informal notification from a chain pharmacy district manager in Camden County, describing authorization delays that were creating what the notification characterized as manageable but persistent queue growth beyond normal operational buffers. The notification included no request for intervention and was logged as informational rather than urgent. By 11:15 a.m., similar notifications had been received from pharmacy operations managers in Hudson, Union, and Ocean counties, each describing authorization processing rates that had fallen below the minimum throughput needed to prevent backlog accumulation during standard business hours. The board's regulatory monitoring systems, which tracked pharmacy inspection compliance, controlled substance dispensing patterns, and adverse event reports, contained no automated indicators for system-wide refill processing delays, as these metrics fell outside the scope of patient safety monitoring and licensing oversight. The delays were occurring in administrative processing steps that preceded the physical dispensing actions subject to regulatory documentation requirements. State health department systems monitoring pharmacy operations through monthly aggregate reporting captured prescription volume, payer mix, and controlled substance distribution, but did not track real-time authorization throughput or verification queue depth. The administrative infrastructure that would allow state oversight of prescription processing velocity existed primarily at the individual pharmacy level, where workflow management systems logged these metrics for internal operational use rather than external reporting. Between 11:30 a.m. and 2 p.m., pharmacy locations across New Jersey adjusted their operational posture to accommodate the sustained reduction in authorization processing velocity. Staff schedules were modified to extend pharmacist hours, reduce lunch break duration, and defer non-urgent inventory management tasks. 73 pharmacy locations contacted their primary insurance clearing vendors to report processing delays, receiving confirmation that system status remained normal and that no widespread issues had been identified across their national networks. 16 pharmacies contacted secondary insurance carriers directly, encountering customer service hold times that ranged from 11 to 38 minutes and receiving guidance to resubmit authorization requests through standard channels. The resubmission process added the requests back into verification queues without addressing the underlying completion rate suppression. Pharmacy Benefit Manager help desk systems recorded 147 inbound contacts from New Jersey pharmacies between noon and 2 p.m., a volume approximately 2.3 times higher than the typical weekday average, but below the threshold that would trigger investigation protocols or escalation to technical operations teams. The contacts were distributed across multiple insurance networks and pharmacy benefit managers, preventing any single vendor from identifying the geographic concentration of the delays. Each pharmacy location was experiencing the problem in isolation from a vendor perspective, even as the aggregate impact across the state's pharmacy network was accumulating into a system-wide throughput deficit. At 2:30 p.m., the cumulative authorization backlog across New Jersey's pharmacy network reached an estimated 3,211 pending refills, representing approximately 4.7 hours of normal processing capacity distributed across a system operating at 64% of normal authorization throughput. The backlog was not uniformly distributed. Independent pharmacies with smaller customer bases and lower baseline refill volumes showed proportionally larger queue growth, with some locations reporting backlog depths equivalent to 8 to 12 hours of normal processing time. Chain pharmacy locations with centralized authorization systems and larger pharmacist staffing pools maintained lower per-location backlogs but absorbed higher absolute volumes of delayed authorizations. Hospital outpatient pharmacies, operating with dedicated authorization specialists and direct integration with institutional insurance verification systems, reported minimal delays but represented only 7% of the state's retail prescription fulfillment capacity. The delays began affecting medication categories unevenly. Maintenance medications for chronic conditions, which comprised 62% of refill volume and typically moved through automated authorization channels, experienced delay rates of 38%. Specialty medications requiring prior authorization documentation showed delay rates of 57%, as manual review steps encountered the same extended verification dwell times affecting automated processes. Controlled substance prescriptions, subject to additional verification requirements and prescription monitoring program checks, experienced delay rates of 41%, with some pharmacies implementing temporary policies to prioritize these authorizations to minimize regulatory compliance risks. Between 3 and 5 p.m., pharmacy operations managers across New Jersey began implementing queue management strategies designed for temporary capacity constraints, applying protocols normally used during staff shortages, system upgrades, or seasonal volume spikes. These strategies included contacting patients to reschedule non-urgent refill pickups, prioritizing authorizations based on medication urgency classifications, extending pharmacy operating hours, and requesting overtime authorization for additional pharmacist coverage. 86 pharmacy locations extended their closing time by 1 to 3 hours. 42 locations called in off-duty pharmacists or pharmacy technicians. The additional staffing increased authorization processing capacity by an estimated 18% across affected locations, but did not restore processing velocity to levels that would reduce the accumulated backlog during the extended operating hours. The strategies were effective at preventing further deterioration, but insufficient to reverse the throughput deficit that had accumulated over 9 hours of suppressed authorization completion rates. Pharmacy management systems logged increasing volumes of patient contact attempts, prescription transfer requests to alternative pharmacy locations, and notifications to prescribing physicians about delayed refills requiring clinical assessment of whether patients could safely extend their current medication supply. These notifications generated additional administrative workload that further reduced available capacity for authorization queue processing, creating a secondary constraint that pharmacy workflow models had not anticipated during design of temporary capacity expansion procedures. At 5:30 p.m., State Health Department officials convened an initial assessment call with representatives from the New Jersey Board of Pharmacy, the state's major pharmacy benefit managers, and insurance clearing platform vendors, after receiving 16 formal notifications from pharmacy organizations describing sustained authorization delays affecting multiple counties. The assessment call confirmed that no individual system had failed, no security incidents had been detected, no scheduled maintenance windows were active, and no regulatory changes had been implemented that would explain the processing delays. Vendor system monitoring dashboards showed normal operational status, acceptable query response times, and transaction completion rates within documented service level parameters. The authorization delays were occurring within normal system operating ranges from each vendor's perspective, but the aggregate effect across the state's pharmacy network had reduced effective throughput below the minimum rate needed to process a standard weekday refill volume. The call participants identified a timing correlation with a scheduled update to insurance eligibility verification protocols implemented by 3 major carriers between January 12th and January 14th, designed to enhance fraud detection through additional validation steps. These validation steps added an average of 93 seconds to authorization processing time, a delay that fell within acceptable performance parameters when tested against individual transaction benchmarks, but had not been evaluated against aggregate system throughput requirements during simultaneous deployment across multiple carriers serving overlapping pharmacy networks. The update was functioning as designed, but the design assumptions had not accounted for the cumulative effect of marginal processing delays when applied across the majority of authorization transactions within a concentrated geographic area. Between 6 p.m. and 9 p.m., pharmacy locations across New Jersey processed authorizations at 71% of normal velocity, while continuing to receive new refill requests at 83% of normal evening volume, a reduced rate reflecting patient awareness of delays and decisions to defer non-urgent refills. The extended operating hours allowed some locations to reduce their backlogs by 12 to 18%, but closures at standard operating times locked in accumulated delays at locations without extended hour capabilities. The authorization backlog at 9 p.m. was estimated at 2,894 pending refills statewide, representing a reduction of 317 from the peak afternoon volume, but still equivalent to approximately 4.2 hours of normal system capacity. Pharmacy benefit managers initiated temporary processing adjustments at 7:15 p.m., including assignment of additional authorization review staff, extension of automated approval windows for certain medication categories, and temporary suspension of secondary validation steps introduced in the recent protocol update. These adjustments increased authorization completion velocity to 84% of normal rates by 8:30 p.m., but could not be sustained beyond standard business hours without approval of operational policy modifications that required additional review. The State Health Department issued guidance to pharmacies at 8:45 p.m., acknowledging the authorization delays, confirming that vendor systems were operational, and recommending that pharmacies prioritize urgent medications, extend operating hours where feasible, and document delays for subsequent operational review. The guidance contained no regulatory directives, as the delays did not constitute violations of pharmacy practice standards or patient safety requirements within existing oversight frameworks. Overnight operations between 9 p.m. and 6 a.m. on January 15th processed the remaining backlog at reduced staffing levels, with 24-hour pharmacy locations and centralized authorization centers working through queues that had been tagged for priority completion. By 6 a.m. on January 15th, the statewide authorization backlog had been reduced to approximately 473 pending refills, representing return to normal overnight queue depth levels. Morning shift operations on January 15th began with authorization processing velocity restored to 92% of baseline rates following complete implementation of the Pharmacy Benefit Manager processing adjustments and temporary suspension of the enhanced validation protocols pending system capacity assessment. The single-day event did not repeat, as the validation protocol updates were modified to implement the additional fraud detection steps through staggered sampling, rather than universal application, reducing per-transaction processing time to levels compatible with aggregate system throughput requirements. No pharmacies reported stock outages, no patients were documented as experiencing adverse clinical outcomes from delayed refills, and no regulatory violations were recorded in connection with the authorization delays. The event existed primarily in workflow logs, authorization queue metrics, pharmacy operations reports, and the administrative record of a day when verification processing persisted just beyond the rate needed to maintain routine prescription access within standard operating timeframes.
Post-event documentation compiled by the New Jersey Board of Pharmacy, State Health Department, and participating vendors between January 16th and January 23rd classified the authorization delays as a capacity planning gap rather than a system failure, noting that all individual components operated within their documented performance parameters while the aggregate system effect fell below minimum service continuity thresholds. The analysis identified three contributing factors: the simultaneous deployment of processing changes across multiple carriers without coordinated capacity assessment, the absence of real-time monitoring systems capable of detecting authorization throughput suppression before backlog accumulation, and the reliance on individual pharmacy operational buffers to absorb processing variations that exceeded the absorptive capacity when sustained across a full business day. Recommendations included development of statewide authorization throughput monitoring, establishment of coordination protocols for carrier policy updates affecting transaction processing time, and review of pharmacy workflow capacity assumptions regarding sustained verification delays. The event was referenced in subsequent Pharmacy Benefit Manager Service Level Agreement reviews, insurance carrier systems integration planning documents, and State Health Department emergency preparedness assessments as a case study in administrative persistence beyond design margins. No formal investigation was initiated, no penalties were assessed, and no public reporting requirement was triggered, as the delays did not meet the statutory definitions for reportable pharmacy system failures, patient safety incidents, or service interruptions requiring regulatory intervention. The event remained documented in operational continuity reports, capacity planning reviews, and the internal record systems that track when routine processes approach but do not exceed the thresholds that separate normal operations from recognized crisis conditions.